Okay. I want to make sure everybody is able to hear. Just for starters, thank you for coming to this presentation. How many of you have a pretty good understanding of fentanyl? Please, by raise of hands. So like a lot of, okay, you've heard of fentanyl, right? And thankfully, we are hearing about it more and more, and we need to be. It's really, really important discussion. Tom Arnold talked about it a little bit this morning, so he kind of gave me a little bit of a teaser for this, which I appreciate. Fentanyl is really becoming an issue, but it hasn't, this tragic wave has not reached us completely yet. So we're in the beginning stages. About a year ago, I was at the American Society of Addiction Medicine conference, and we were having just a visit with some of the people that I already knew that were at the conference, and we were talking. We were talking about fentanyl, and it was the topic of conversation there. And I come home to Utah County, and find out that there's a lot of things not being said about fentanyl. So I think it's just a really important discussion that we will need to continue to have. Okay? What is fentanyl? So for starters, fentanyl was a pharmaceutical that was invented and approved by the FDA in 1959. It is a synthetic opiate. What does that mean? It is not derived from the poppy plant, like heroin or morphine or codeine. It's synthetic, meaning it is made in a laboratory. It is a very, very strong opiate. It's about 100 times more potent than morphine, okay? Heroin is about 1-to-1 equipotent with morphine. So fentanyl is about 100 times more potent than heroin. It started off in 1959, but since then there have been lots of different fentanyl products. The main product of fentanyl is it's usually used as a transdermal patch or a topical patch that you apply on your skin. The concentration of these things, I don't know if you can see this really well right here, but it's 75 micrograms per hour, okay? When we're talking about fentanyl in the medical world, we usually talk about fentanyl in microgram doses, whereas almost all the other opiates you hear of milligram doses. The reason for that is because of its potency. You don't give someone a milligram of fentanyl. You give someone micrograms, okay? It was developed for pain management in severe cases. So we're talking about people with really bad end-stage life cancer-type pains. Things that don't respond to the traditional opiates because the potency needs to be higher. And as the potency increases, what else increases? Say it loud. Dependency. What else? Risk for what? Overdose, right? And overdose is a really funny word. We talk about overdose in our community as someone who basically stops breathing or they pass out. But an overdose means any dose above what is therapeutically intended. So as you increase the fentanyl strength, you're going to increase side effects, you're going to increase the effect, but also an over effect. Okay? Because fentanyl is so powerful, because fentanyl is so good at doing what it does, it has also been more and more over the years diverted for abuse purposes, recreational purposes. People are very creative, right? You could take a fentanyl patch and you can boil it, or you can suck on it, or you can do whatever you need to do to get the effect that you're looking for. Well, it wasn't that long ago. It was around early 2010-ish that fentanyl really started to be that we started to realize it was in the heroin supply. The first time I heard about it was during my fellowship in addiction medicine back in Baltimore, where I heard people talking about this thing called China White. It was like, it's the pure heroin. It's called China White. And it was called China White because it came from China and because it was much whiter substance than the heroin that the community was used to using. So it's being put into heroin, okay? Why? Because it's more potent and because it has a greater effect. But there are some other reasons we're going to talk about in a couple of seconds. Many people who are using fentanyl don't know they are using fentanyl. That's probably the biggest key that I want you to take home today. If you don't remember any of the other stuff, fentanyl is scary, people don't know they're using it, and they die. Those are the 3 main points that I want you to, now you can go. And if you go, you've learned what you need to learn, except the code word, which you have to wait till the last slide. But that is, if you want to fall asleep now, wake up at the last slide, that's fine. And then the rest of you that want to stay, I appreciate it, okay? Fentanyl is produced illicitly. Our primary fentanyl illicit producer for our country is Mexico. It is made in China. It is made in other places as well, but most of the fentanyl that we get here in the United States is coming across the border from Mexico. So let's take a case. Who loves to read words on a PowerPoint presentation and would love to be the reader for this case? I'll give you the microphone. Okay. No pressure.
26-year-old male college student who started smoking THC at age 17, sent to treatment where he learned about other drugs. After discharge, he began to experiment with opioids and liked their effects. Moved from the East Coast to Provo to attend BYU and began using heroin when depressed, then progressed to IV use and enters treatment again due to court mandate for violation of his probation due to a recent felony charge for purchasing fentanyl online and distributing to others.
Not your typical BYU student, I don't think, right? Every case that I'm going to present to you is a case that is a real individual that I have treated, okay? This was one of my first exposures to fentanyl here in this area. I think the microphone is the microphone still working? Okay. So he was one of the first people that I really saw that used fentanyl or diverted fentanyl. And it kind of just shocked me. I said, well, how are you getting your fentanyl? He's like, I buy it on the internet. I buy it on the internet, on the dark web. I was like, how do you get to the dark web? I have no idea. So he was diverting this. He was distributing it, okay? So what we did for this individual was we got him on buprenorphine. And he did quite well, actually. Buprenorphine, we'll talk about it a little bit later, but buprenorphine is a partial opiate that blocks the receptor's ability to accept fentanyl. Here are some of the street names that are out there. This is not an all-inclusive list, but some of these names are names that in the past, in different areas of the country, have been used for fentanyl. Street names tend to be geographically diverse, so it depends on where you are in the country, what they tend to call things. A lot of people are just calling it fentanyl now. So, you know, I think a lot of the folks, there's a lot of publicity about fentanyl, so I think fentanyl is a good name to just use. Who would like to read another case? Right over here, okay. I'm just going to go down the line.
23-year-old male recently intubated for fentanyl overdose. At the time, he was smoking 3 to 4 tabs of fentanyl daily. While he was hospitalized, he was on a fentanyl drip and then transitioned to oxycodone. He is currently complaining of withdrawal. He is not currently in treatment facility due to lack of availability. Currently, he reports severe opioid cravings. Last reported use of opioids, fentanyl, was February 12th.
So this is a really recent case. This kid, really young, he knew he was using fentanyl. That's what he was looking for, okay? So yes, some people don't know they're using it, but some people, that's what they're looking for. And his mother lived in Las Vegas. His mom drove up here because he couldn't find a place to get into treatment. And she just got a hotel, and she just had him in her hotel room because she was worried that if she wasn't watching him constantly, he would use. So when we brought him in, his mom had been with him in the hotel room for almost a week trying to find a residential place that would accept him on Medicaid. And when I asked him when he last used, yesterday, his mom was like, how in the world? So he was very creative, and we were able to get him taken care of. Again, we used buprenorphine in this case for this individual. Now he's in residential treatment. He's actually doing really well right now. So these are real cases. Most of my cases are very recent cases. This case also highlights something that I think is really important to note, which is that there are a lot of people in the medical community that are still grappling with this issue. So what they did in the hospital was they put him on fentanyl, on a fentanyl drip, because they couldn't figure out how to manage his withdrawals. That's kind of weird, okay? Then what did they send him home on? Oxycodone. So we're still kind of trying to figure out how to help the medical community learn how to deal with medications to treat withdrawal and to treat opiate use disorder. So this is a very recent case that shows that. So we've been tracking overdose rates for some time now. If you look at the trends from 1999 until 2019, which is the most hard data we have, we do have in some preliminary data from the last couple of years, but this is, as far as full published data that's been validated, this is the best we have right now. In 1999, less than 10,000 people were dying from opiate overdoses in our country. But then look at 2019, 20 years later, 50,000 people a year. This is nothing compared to what we're seeing now. The preliminary data for 2022 is somewhere around 140,000, okay? We didn't start tracking fentanyl overdose rates until about 2011. So 2011, the portion of people who died from fentanyl overdose is that little red square. Watch what happens over time. 2012 stays about the same. 2013, doubling. 2014, another doubling. Okay? It keeps growing. How alarming is this? What happens in 2020? Right. This is the fentanyl overdose rate of 2020. Just looking at that graph is just very alarming what is happening here. This is another way of showing you the trends for different substance overdoses. So we have different things like benzodiazepines, heroin specifically, and synthetic opiates, which is basically fentanyl. And I just want to highlight those two trends. Here's heroin. Notice that. Of all the talk about heroin over the last 20 years, this curve doesn't really look that impressive for increase, does it? It was increasing pretty quickly right up here. But then what happened? It starts to taper down a little bit. What happened? Did we fix the problem? Look at what happened with fentanyl. That's what happened. Fentanyl is taking over. Heroin is now the new fentanyl is the new heroin. That's what you need to remember. What does fentanyl look like? The answer is yes. It looks like whatever it wants to look like. These clandestine labs, they make it look like all kinds of things. These are actual pictures of when the DEA seizes drugs. These are actual pictures of stuff they have seized. It can look like a crystal, like this one here. It can look like a powder, which is kind of what I think a lot of people think of when they think of heroin. Or it can look like, whoops, let me go back. It can look like this. These look fun, don't they? These look like something my kids would say, I want one of those. These are actually pressed to look exactly like oxycodone 30. Now, but they're multicolored, which is not normal. And then They can make them into any pill they want. In fact, that's what they have been doing. These labs are making them look exactly like a Percocet, exactly like an oxycodone. The follow-on problem from that, people think they're taking one thing, but really it's something else. This doesn't sound like a very good business model for the drug dealer. So I'm going to sell the most potent thing, and then it'll kill my customers. Okay? So I asked the question, why in the world would we put fentanyl in this stuff? I mean, I know it's more potent, but I mean, I don't want to kill my customer base. Economics drives addiction. Economic drives everything we do in addiction. So let's just talk a little bit about the economics of it. Heroin costs about $6,000 to produce a kilogram. Because you have to grow a ton of poppy plants. You have to tend them. You have to harvest them. You have to isolate the heroin from that poppy plant product. And then you have to make it into a viable product, like a powder or something. $6,000 to produce. You can sell that for $80,000. So $80,000 for $6,000 sounds like a really great business model, right? I can earn $74,000 by selling heroin. Pure fentanyl is created in a lab. I don't have to plant flowers. I don't have to harvest them. I can just create it. It costs about $3,500 to create about a kilogram of heroin. And because fentanyl, because fentanyl is so potent, you don't sell a kilogram of fentanyl pure. You cut it or mix it with a bunch of other contaminants that are usually inert things, whether it's baking soda or whatever you put in there. And 1 kilogram of fentanyl sold can actually, once it's cut, yield about 16 to 24 kilograms of product, which can yield you a profit of $1.6 million. This is why fentanyl is the new heroin. It's cheaper to make and so potent, you can make just so much money. Who cares about my customer base? And the other problem is there seems to be a never-ending line of customers right now. So this is the reason. 20 times the profit, it's pure economics. You can see why this is an issue. What happens to the consumer, not such a good thing, especially if they don't know what they're getting. Case number 3. Who wants to read it? This is the people.
Okay, patient is a 46-year-old female who reports at age 22 she was prescribed daily opioids for endometriosis. Yes, and back pain. She reports that in age 35, she no longer had insurance, so she was introduced to heroin and has used off and on since. Reports she has been trying to get off the heroin for years, and although she reports her withdrawal is not severe, she feels like her pain is unmanageable. That she reports back to heroin, is looking for other options. Last reported heroin was this morning, March 2nd at 4 a.m.
This is a patient I saw yesterday. I asked her if she'd ever used fentanyl. She said, what do you think? No. What is fentanyl? We tested her urine, and I said, it's what you're using because it's in your urine. This presents a problem because if you're not testing for fentanyl specifically, you will often miss the boat, which I would have missed with her. What do we do for a patient like that? Do I just start her on Suboxone? I can't do that right now. And I'll explain a little bit about that. Fentanyl is contaminating everything. If there's a drug out there that's being sold illicitly, I promise you it has been discovered to have fentanyl contaminating it somewhere. Marijuana? Yes. Cocaine? You bet. Methamphetamines? Absolutely. And I have had patients come in that have never had heroin, that have never used opiates, that have only used meth, and they're positive for fentanyl on their UA. They come in, they're like, I don't know what is happening, Dr. Bush. I'm having the worst, most absolutely abnormal withdrawal symptoms from my meth. It's like it's different now. I can't do this. It's like I'm throwing up, I'm nauseated, I'm having diarrhea, and I'm like, this sounds like opiate withdrawal. And it's because they're on fentanyl. They don't even know they're on it. So beware. So what does fentanyl do? It's an opiate. So it does what opiates do. It makes you relaxed. It makes you euphoric. It makes you have your pain controlled. It makes you constipated. It makes you drowsy. And then it makes you stop breathing. That's how fentanyl kills people. That's how opiates kill people. That's how benzos kill people. It reduces the drive in the brain, the central part of the brain that drives you to breathe. It reduces the drive. If you get enough of it, it reduces the drive down to a low enough amount that you can't breathe enough to keep your brain oxygenated.
Fentanyl's in everything out there now. These aren't the drugs of 10 years ago.
Illicit fentanyl has 50 times the strength of heroin. As little as 2 milligrams can be fatal.
Before Stephen and Andrew passed, I didn't really know anything about fentanyl.
Many young adults have never heard of illicit fentanyl. This increases the risk of death through experimentation.
They are putting it in everything to make all their drugs more potent and more addicting.
Illicit fentanyl is being used to make counterfeit prescription pills, as well as lace drugs of all kinds.
They were good kids that made an innocent mistake.
Young people are supposed to learn from their mistakes, not die from them.
He thought he was being safe. He took one Percocet, and now he's dead.
This is a drug like we've never seen before.
People are being poisoned through deception. They think they're buying one drug, but receive another that kills them. Fentanyl is the #1 killer for people ages 18 to 45. Anyone, anywhere, anytime. Fentanyl kills. For more information, please visit Matthew's.
Think about that for a second. What is the #1 killer in the United States for people 18 to 45? It's not automobile accidents. It's not any medical condition or infection. It is fentanyl. That is really scary. Overdose of fentanyl. So we talk about overdose, and then we can talk about lethal overdose. So an overdose, meaning it can send you into a comatose state, can happen with as much fentanyl as is about a grain of salt. 1 grain of salt. A lethal dose of fentanyl is around 3 to 5 grains of salt size. So for some perspective, a kilogram of salt has about 15,500 grains of salt in it, which means 1 kilogram of fentanyl has about 3,100 or more lethal doses in it. If it costs $3,500 to produce fentanyl and it kills about 3,500 people, that's a person per dollar. That is a powerful, scary thing to realize. This is the tip of a pencil with a lethal dose of fentanyl on top of it. That's the size we're talking. So what do we do when we have patients that are using fentanyl? Because all of you, raise your hand if you're in the treatment industry. So there's most of us. You all have patients that are using fentanyl, okay? So what do we do? Obviously, we treat them with the same level of respect, the same level of care that we would anyone else. We give them the psychotherapeutics they need, the treatment that they need. They need medications, okay? There's a stigma about medications for opiate use disorder, methadone, naltrexone, and buprenorphine, that needs to be broken down. There are too many people dying from overdoses of medications to hold fast to this philosophy that it is bad to get on a medication for opiate use. It would be the same thing as saying insulin is bad, we shouldn't give it to a diabetic. We're withholding these medications, these life-saving medications from people, and they can die as a result. It's a patient safety issue. So what do we do medically? Well, first of all, if you're not testing for fentanyl, you're not testing. If you don't have test for fentanyl on your drug panel, you do not know what's going on. 2 years ago, we started the idea of testing for fentanyl. 1 year ago, we started testing all of our patients at Wasatch. And I can tell you, in the first 6 months we tested, I had maybe 5 in the entire 6 months that came up positive. That was only a year ago, people. Now, it's about 1 in every 5. It's scary how quickly this thing is taking over. We were a little bit of a protected spot somehow in Utah County, but that tragic wave it's coming, it's cresting, and it's gonna drown us all. So you gotta test for it. Because it's a synthetic opiate, it does not trip a positive on an opiate screen or on a heroin screen, okay? At that ASAM conference that I was telling you about at the beginning of my presentation, most of my colleagues that work on the East Coast and on the West Coast have said, you guys still test for heroin? When we test them for heroin, they come up negative every time. That means that what they're getting has nothing to do with 6-monoacetylmorphine, which is heroin. It has everything to do with fentanyl. So around the country, that's the trend that we're seeing, is that fentanyl is the heroin. They still call it heroin on the street, but it isn't heroin. It is fentanyl. So you got to test specifically for it. If your drug, it doesn't come on the standard drug test panels. You have to get a separate test for it, okay? And so make sure you do that. And I just talked about number 2. Many places in the country are seeing people who don't use heroin at all. So if you get a test, a urine test on someone who says they're using heroin, and it's negative for heroin and negative for opiates and negative for oxycodone, you can bet they're using fentanyl. Okay, let's talk about fentanyl's fat solubility. Fentanyl is fat soluble. Now, most of us are pretty familiar with the fact that marijuana and THC products are fat soluble, and that is why if someone's using cannabis products regularly, how long does it stay in their system? Before their urine is negative, it can be a couple of months, right? So we're familiar with that concept. The reason for that is that cannabis is fat soluble, and it builds up in the adipose tissue or the fat tissues of the body. Then, as you stop using it, it will start to clear. Fentanyl has a similar property. It is fat soluble. If you use fentanyl regularly, it will build up in some of your fat tissues. That means that if you stop, you're not really stopping right then. You stop taking it in, your body will give you whatever was stored in the fat cells for a little while longer. So you can stop fentanyl today and still be positive 3 to 5 days from now. And that changes things. Because again, if somebody comes in on heroin, traditionally I would say stop the heroin and the next day I'll give you the Suboxone and you'll be fine. Because I have to wait for that 24 hours to make sure I don't precipitate some withdrawal. We can't do that with fentanyl. We have to wait longer. We have to wait 3 to 5 days to make sure that the fentanyl has cleared. We need to do a UA, make sure it has negative fentanyl before I can even think about giving them buprenorphine. Okay? How do you think that's going to go with your clients? Please stop for a week. Come back and let me know, and then I'll give you started on some medication. Are you going to see them in a week? Maybe not. And so that fat solubility is a very important concept to understand. Okay? Same thing with naltrexone. You can't just say, so typically we would say, if I want to put you on Vivitrol, you got to stop all your opiates for a week. Nope, with fentanyl, it's got to be longer. Okay? So what have we done instead? Well, we've started doing these things called low-dose inductions. Another name for them is the Bernese method. Another name for them is a micro-induction. How many of you have heard of this before? Good. So a micro-induction or a low-dose induction is where you give the patient tiny doses of Suboxone, like a 0.5 milligram for the first 2 days, and then you increase it in a protocol method. There's different methods, and you can do it slightly different, increasing it at different speeds, depending on if they're inpatient or outpatient. But basically, the idea is if you start low enough dose of buprenorphine that you don't precipitate withdrawal, you can actually increase it while they're actually still using fentanyl, because it will ease the buprenorphine on and basically ease the fentanyl out and not precipitate withdrawal. So low-dose inductions are being used, especially in opiate treatment programs and in inpatient centers. It's really easy to say, okay, I'll just give you your methadone, and we'll just start you on buprenorphine at really low doses, and you'll stay on your methadone all the way until you get to 16 milligrams of buprenorphine, and then you'll stop your methadone. It's a little harder to do this when someone comes in and they're using fentanyl on the street. Do you tell them, keep using the same amount you're using, and I'll give you a little bit of buprenorphine to increase while you do that? That is actually what's being done in a lot of places, and it sounds scary. It sounds like, why would you ever tell them to keep using what they've been using? But it's actually been shown to be very helpful to get them to come to you and get into treatment. So you can see we're grappling with this issue. We're trying to figure out how to do this in the most ethical way possible. But in order to decrease precipitated withdrawal and have a chance at getting this patient off of that fentanyl, you may have to do it in a stepwise, gradual process. The other problem we're noticing at opiate treatment programs and in other medication programs is that we're having to give patients way higher doses of buprenorphine and methadone than we're used to. So traditionally, 5 years ago, most methadone treatment programs would say, we don't go above, any takers? For Suboxone? Okay, I'm talking about methadone right now. So about 5 years ago, if you were in a methadone treatment program, we say we usually don't go above 100. Is usually what most methadone treatment was like. They start at 30, so you're right about that. But most programs about 5 years ago were saying we don't typically give more than 100 to 150 milligrams of methadone per day. That's kind of a target dose. You'd start them at 30, and then you would increase them as they can. But most programs would start getting uncomfortable at doses above 150. Certainly above 200. And they're like, this patient should not be on that high of a dose. So what do you think doses are typically for people who are on high-dose fentanyl that need methadone? Keep going. Okay, we are routinely seeing patients that are requiring greater than 500 milligrams of methadone in order to maintain and not have withdrawals, because that's how potent fentanyl is. Do you think that makes any methadone program or opiate treatment program comfortable? Absolutely not. So it's changing the way we're having to look at methadone. And it's scary, because we don't want to give anybody 500 milligrams of methadone. But I've heard of recently a lot of methadone programs that have been pushing that envelope to try to save lives and getting people way higher than 500. So we have to start, this tragic wave is changing everything. It's changing everything about how the patients are in the community, the users are interacting with opiates, and it has to change how we interact with it as well. If you go out and you Narcan someone who is on high-dose fentanyl, sometimes one dose isn't enough. Sometimes you have to give a double dose. And because of its fat solubility, that Narcan, how quickly does Narcan wear off? Does anybody know? It can wear off within 5 minutes, right? There have been people who have died after being Narcan or Narcanized because they were on high-dose fentanyl. They get Narcan, get another dose of Narcan. They're in the EMS, EMS is called. The paramedics come, they give them the 2 doses. They're in the ambulance on the way back, and they die. Because the Narcan wears off, and the fentanyl comes right back. Boom, and they die. And so we're having to give these people like tons of Narcan in order to keep them alive long enough to get them to the hospital so they can get something that will stay in their system for longer. Okay, if you're not scared enough, I'm going to talk a little bit about something that keeps me up at night. Fentanyl analogs, which an analog is basically a compound that has great similarity. It usually means you take a compound and you add like a certain moiety on that chemical structure, like an OH group or a nitrogen group or something. So it's basically like the similar compound with a slight tweak. There are a lot of fentanyl analogs out there that are finding their way into the illicit supply. I'm going to talk about 3 of them. The first one is 4-phenylfentanyl, which is 8 times more potent than fentanyl. The next one is called sufentanil. Now, sufentanil actually was approved by the FDA for use in humans. Some of you may be scratching your head of like, why? Why? Well, a lot of people in end-stage cancer need really high doses of pain medication. A lot of people who are super obese, we're talking about the people on that show that you probably have watched, but you won't admit it, might need higher doses of medication, so they might go for sufentanil in that case. It's very unusual medication to see used in the past, but now because of the fentanyl era, we're seeing more people needing something like this because their tolerance is so ridiculously high. It's about 5 to 10 times more potent than fentanyl. Carfentanil is the scariest one of the bunch because carfentanil is 100 times as potent as fentanyl, which means it's 10,000 times as potent as morphine. And it is actually a veterinary medicine called Wildinil that they use to tranquilize elephants, rhinoceros, and hippopotamus. And guess what has been found contaminating our heroin supply in certain places? Carfentanil. If it takes 1 grain of salt equivalent size for fentanyl to overdose you, what do you think it's going to take for something like this? And what if it costs about the same amount of money to produce? That is scary to me. That kills people way faster than fentanyl does. You have a question? Oh, xylazine. Yeah, it's not the same thing. I don't think so. It's not. Yeah, and if I had time, we could go into talking about that. That's not the same thing. It's not an opiate. The xylazine is not an opiate, but it is a tranquilizer, a heavy one. So here is the lethal dose of heroin. Right here. Okay? This is the lethal dose of fentanyl, and this little tiny blip you can see in that tube is about what it would take for carfentanil to kill you. You couldn't even see it if it was coating an envelope and you licked it. You die, right? Carfentanil has been implicated in killing police dogs who are simply just looking for drugs, and they inhale it and they die. So it's kind of a scary sort of thing. I'm not here just to scare you, but that kind of stuff scares me when I look at these patients who don't even know what they're taking into their body, and they're toying with. It's definitely a game of Russian roulette with this kind of stuff. So what can we do? So we've talked about medications for opiate use disorder and that we need to do a better job at destigmatizing that and helping our patients come around to it. And as a side note, I think that is very important. I have actually worked with addiction rehab centers in this county that have talked their patients out of the medications that I have prescribed to them. Why? The stigma is real. I sit down and I do a medical evaluation with the patient and I say, okay, I think you need buprenorphine. And they say, that's what I want. And then we make a plan. And I meet with them the next week and they say, I don't want that anymore. And I ask them why. Because it's just trading one addiction for another, and I want to be truly clean and sober. And I say, well, what changed your mind? Well, everyone here is telling me that I shouldn't be on it. And so that stigma, that I understand why it's there, right? There are people who do prescribe these things incorrectly, do abuse them, but there are people who abuse their thyroid medication, there are people who abuse their insulin, and I'm pretty sure that is not a good reason to take everybody off their insulin or their thyroid pills. So we need to be responsible as prescribers, but we also need to be responsible as medical professionals and mental health professionals at helping our patients get the life-saving medications they need. But as a community, there are other things that we can also consider. Harm reduction means that you're reducing the risk of someone without necessarily stopping the behavior. So, classic harm reduction strategy is safe sex education. We know that if you do have sex, we want it to be the safest way possible. And so translating that kind of mentality into the drug using world is a very debatable topic, and it's very controversial because there are people who feel that if you do harm reduction, you're endorsing or enabling drug use. But the data is very convincing that it does reduce all of the different bad things that happen when you use drugs. Reduces infection rates, reduces overdose rates, reduces death. So we need to at least be willing to think about it. So some harm reduction strategies include fentanyl test strips. How many of you are familiar with this idea? So this is like at a bar, at a local bar, there will be a big kind of glass jar with a bunch of test strips in it so people can grab them and go into the bathroom and test their heroin to find out if it has fentanyl in it. Because it might just save their life. Okay? Yes.
So really quick on that, because I pass them out a lot, but then I think to myself, because I'm in recovery,
Yeah.
like if I was testing my heroin and it had fentanyl, like as an addict, am I really going to get rid of it, or am I just going to do it? You know what I mean? So it's really...
That's a great question. So her question was, do they really work? So data shows that fentanyl test strips reduce overdose and death in patients or in the community that uses opiates. That does not mean that it prevents all of them, right? This is not called harm prevention, it's called harm reduction, which means that there are some people, like my first case, that were looking for fentanyl, or second case. So, is it possible someone like, I need that test strip so I can find out if I have fentanyl in there because that's what I want? I suppose that's possible. But there are a lot of people out there that are scared of fentanyl. They should be. And so if they have a test strip, it might actually save their life. They're interested in being careful, okay? Correct. It could, so looking into the logical thought process of someone who's using, they could say, well, this has fentanyl in it, so I'm going to get my buddy to come watch me. And that way, here's some Narcan, can you just in case, right? And so fentanyl test strips are controversial. There are states that don't allow them to be sold, but this is an idea of how to prevent the catastrophic loss of life. Education is huge. We need to educate people. As we've said over and over, patients don't know what they're using. These people don't realize what's in the drugs they're using. So the more education we do for ourselves as the treatment community and to the individuals that are in the using community will help reduce some of that harm. Narcan rescue kits. We need to do a better job at endorsing their use, at handing them out. They're free. If you want them, call the number, the free Utah number, the Naloxone Now number. They'll send them however many you want. You can Google it. It's really, this is not something that we don't have access to, okay? Syringe services programs, which have previously been called needle exchange. Syringe services programs actually reduce harm. They reduce overdose deaths, and they actually have been shown to increase entry into treatment because most syringe services programs have trained professionals that talk to people and ask them if they want any resources. They have handouts and pamphlets giving out to people, and it actually has been shown to increase the number of people who go into treatment because they realize, hey, they actually care about me. They're giving me a clean needle. That's going to make me think a little bit more about doing treatment, and then they do. So safe spaces to use is another really controversial topic, but there are some places in the country that are actually advocating for and operating small use spaces within large metropolitan areas where users of drugs can go there and use under direct observation of somebody who is there in case they need something, in case they overdose, or to provide them resources. Again, these things are showing, the data is showing that you have higher entry into treatment because, again, you're finding people and trying to meet them where they are willing. Mobile crisis teams are really important. And then when you're meeting with your patients, doing motivational enhancement with them to try to figure out where you can meet them. Where are they so that you can help them? And all these harm reduction strategies are not strategies that we use all the time, and a lot of states have laws against some of them, but they are things that we have seen have helped. Going forward, fentanyl is the wave of the future for this community that is using drugs, especially for the opiate population, but including all the other drug-using communities. If they're using drugs, the likelihood they're using fentanyl is very high. So we can expect that we will see this more. We will grapple more and more with the fentanyl issue. And it's imperative that we defend the safety of our patients by learning ourselves about fentanyl. So today you took the first step. Congratulations, you did it. Thank you, good for you. And continue to do that. Continue to educate yourself. Then pass that knowledge on to your family and your friends and your patients so that the more education we do, the better we can start trying to handle this problem. Okay, now you've waited around for the code. This is the code. It is time for questions if you have them. I'm going to open it up. That's all I have.
Prisons, military bases, none of this is being offered. Any tips?
Okay, so I'm gonna just correct you a little bit because I was in the Army for a long time, and we do offer, in the military, they do offer buprenorphine and even allow methadone in certain cases. But it's not at where it should be. And in the prison system or in the jail system, we're actually making some headway. For example, I had a meeting this week with a jail for a community reentry program to give out Sublocade injections to people who are incarcerated. That's a big, huge win. I mean, you have no idea how big that is. They already have a program for Vivitrol for people who are incarcerated. So the jail systems are, we are behind the curve. There are a lot of states that are regularly providing medications for opiate use disorder in their incarcerated communities. Yes. So it is important that we make more headway because we really aren't where we need to be, but I do see that the changes are happening, which is very encouraging. Because the recidivism rate for folks who come out of prison and jail is super duper high. If you can give them an injection that lasts for longer than 30 days that will prevent them from having a relapse, overdose, and death, then you're providing them an opportunity, a window of opportunity to get into and stay into treatment. And that's what we're seeing. So that's encouraging. Other questions? Yes, just so everyone can hear.
I don't specifically work in substance use, but for my clients who tell me that they use edibles, how likely is it that fentanyl is getting into their edibles?
That's a super great question. And as I was practicing this presentation with my wife, who also is not in the healthcare or medical or mental health community, that was a question she asked me. She said, well, my son was there. He's 11. And he said, if I take a vitamin or a Tylenol, do I have to be worried? And I said, I don't think you have to be worried. But my wife's question was, what about edibles? It could be in a brownie or a cookie, right? So we haven't seen, and I'm going to say the word yet in capital letters, we haven't seen yet a large contamination of fentanyl in edible cannabis products. There have been some that have been reported. Others that have been reported have been found that it was a false positive test. But that is a very good question. As far as we have seen, it has not, and that's what I mean about this wave approaching. I think that it will, because fentanyl is orally bioavailable, which means it works by just swallowing it. In fact, there is a fentanyl lollipop that is a prescription. So you can imagine that it can be put in edible products and then with catastrophic consequences.
Thanks, Dr. Bush. So I do assessments sometimes for people, coming, first contact, coming in seeking for treatment, and some of them are using opioids, some of them are testing positive for opioids. As an agency and as a community, like, what is the strategy to, this person walks in the door, they're using, say, fentanyl, how do we get them to the medical provider so they can get some medicine?
I promise that wasn't a plant. That is really, really important, because there are not enough providers in our community that prescribe medications for opiate use. And so we're working on that, right? December 22nd, the DEA removed the requirement for the X waiver. If you hadn't heard that yet, the buprenorphine waiver, which means you have to have the special training and the special license to prescribe Suboxone, has gone. It's gone. It doesn't exist anymore. It's not a requirement. Anybody who can prescribe any medication can prescribe Suboxone or Sublocade or any of that stuff. So that is one step, hopefully, forward to trying to increase the number of people that can have access to those medications. It is a work in progress. There are people that are federally lobbying that methadone should be allowed to be prescribed in an outpatient clinic, because there is nowhere close to the number of methadone treatment programs that we need. And so there's an argument that that should be something that any doctor or nurse practitioner can prescribe. I don't know how I feel about that. I'm still uncomfortable with the idea of methadone being prescribed in a clinic, but that's the question of the day, really. How do I get my patients the medications they need? So finding the referral sources that you have for medications will be critical. It depends on your patient population and what insurance they have of who they can see. So if you have specific questions about like specific insurance company coverage for people who prescribe medications for opiate use, I can get with you after the presentation and give you some ideas. But look for places that prescribe opioid use medications. Methadone treatment programs, or OTPs, outpatient treatment programs, or opiate treatment programs, are a good place to start. Most of them, if they can't accept your patient, are going to tell you where you can look. They'll point you in the right direction. But if you see someone who's using fentanyl, you need to almost equate that to needing medications for opioid use disorder, because without it, their rates of relapse are about 90%. So just keep that in mind. I also recognize that we're at 11:17, and so I do not want to keep anybody past the time that they need to be here. So if you leave, it's not rude. You're welcome to stick around for a couple of minutes.
As a medical professional, what do you think the disconnect is from, or the hesitation from the state of Utah obtaining more MAT treatments or things like that? Like, I come from a state, fortunately weed is legal, but I worked in outpatient and MAT treatment was an option significantly more than what is offered here in Utah, and I work with a division, so a lot of times it's really hard to find treatment providers that will treat the parents that we're working with that are struggling with substance.
I'm just going to repeat what she said. She said, what is the state of Utah doing to try to help increase access to medications for opiate use. So the biggest problem that we have in the state of Utah is not any program that receives federal funding. Any program that receives federal funding by law is required to offer medications for opiate use. It is the commercial, privately owned rehab facilities that don't have any obligation to offer those things, and they seem to be the ones that are still back in the like 20 years ago philosophy that you shouldn't be on these medications. And so what we're doing is we're trying, from an advocacy side, I'm very involved in trying to work with the Department of Health and Human Services, their Office of Licensing, to try to hold these programs accountable for offering standard of care instead of medical neglect for their patients. So we are working on it, but you know how fast these kinds of things happen. Any ideas that you have for making that happen are welcome. So that's good. Any other questions that you have? If you want, I will stick by. If you want to come talk with me offline, that's fine too. Thank you.
As a reminder, the next session is at 11:30, and Dr. Bush does also have another pre-recorded session that is available in the conference portal. That's super good. Thanks.